Despite billions of dollars invested in cloud-based electronic health records, the digital databases hospitals use to store patient data, the actual point of care relies on archaic, analog paper clipboards. This diagram illustrates a standard 15-minute clinical appointment. When a patient fills out a physical form, the manual intake and subsequent administrative transcription consume up to 14 minutes of that time block. This is the first-mile failure. You might assume the solution is forcing patients to use digital hospital portals or custom mobile applications. But building these systems requires massive IT infrastructure budgets to integrate custom application programming interfaces, or APIs, which allow different software programs to communicate. There is also a strict legal barrier. Centralized third-party portals automatically trigger liability under the Health Insurance Portability and Accountability Act. Specifically, hospitals must sign a Business Associate Agreement, or BAA, which legally exposes them to massive fines if the third-party vendor experiences a data breach. Centralized data structures fail at the physical point of intake. You cannot solve a localized data bottleneck by simply adding more remote cloud storage. Aura hOS circumvents this bottleneck by transforming the patient's own mobile phone into a sovereign edge-computed node. Edge computing processes data locally on the physical device rather than relying on a distant cloud server. Clinical data moves directly from the patient to the physician using a peer-to-peer connection called the transient handshake protocol. This specific protocol is architected so that data travels straight from the phone to the doctor's screen. It completely bypasses centralized corporate servers during the transfer. Deploying this direct transfer eliminates the 14-minute paperwork penalty entirely. It requires 0 lines of complex IT integration from the hospital's engineering team. By moving the origin of health data directly to the biological edge, the patient themselves, clinics achieve frictionless interoperability while actively avoiding third-party data silos. The foundation of this architecture is a strict local-first requirement. All clinical history is stored directly on the physical mobile device, not on a web application. This diagram shows the local encryption mechanics. Data is locked within an SQLite database using AES 256 GCM encryption, a highly secure military-grade algorithmic standard. The decryption key is generated by and tied directly to the hardware's biometric secure enclave, such as Face ID or Touch ID. To prevent data loss if a device is destroyed, the phone performs a cloud backup. However, the device syncs only a mathematically locked scrambled ciphertext payload to the backend infrastructure. This creates a zero-knowledge state. The central managed backend acts strictly as a blind relay. It possesses 0 decryption keys and cannot read patient data. Because the server holds no keys, Aura operates strictly as a personal health record under the FTC Health Breach Notification Rule, or HBNR. The HBNR is a federal regulation governing entities that manage consumer health data outside of traditional hospital networks. This specific FTC HBNR classification completely exempts the system from standard HIPAA BAA requirements. The software acts purely on behalf of the patient, not the hospital. Architectural cryptographic blindness actively shields partnering clinics from catastrophic third-party data breach liabilities. When the patient walks into a physical clinic, this encrypted data must transfer to a doctor without relying on cloud APIs. To initiate the transient handshake protocol, the patient's device generates a secure ephemeral QR token. The clinic's reception staff scans the QR token using any standard intake scanner or an iPad. This diagram shows the resulting network action. The QR scan instantly establishes an ephemeral network tunnel directly between the patient's phone and the provider's local screen, routing around central servers entirely. The AES encrypted clinical JSON payload, a lightweight file format used for structuring data, is pushed directly through this isolated tunnel. Decryption occurs locally on the provider's machine. This instantly yields a highly structured clinical history on the doctor's screen. This exact formatted data maps seamlessly into legacy electronic health record workflows like Epic or Cerner, completely eliminating the manual entry phase. The outbound handshake democratizes interoperability by making the patient the secure, offline-capable courier of their own medical records. At the conclusion of the visit, the clinic must securely return discharge summaries and lab results to the patient. To do this securely, the system uses a 0SSN Unique Patient Identifier, or UPI, model. This avoids the severe security risk of collecting and storing social security numbers. The clinic's local browser packages the medical documents directly at the front desk. As shown in this diagram, the clinic locks the payload locally within their own browser. They utilize the patient's UPI as the mathematical encryption anchor prior to transmission. The ciphertext blob is pushed blindly through the central cloud infrastructure back to the patient's waiting device. In the final step, the patient's device uses its local hardware keys to decrypt and merge the new documents into their encrypted timeline. This closed-loop delivery process completely circumvents clunky patient portals and forgotten passwords, maintaining perfect end-to-end encryption. Interoperability must survive in entirely disconnected or legacy environments where digital network handshakes are blocked. If the network fails, the system executes an OCR JSON fallback mechanism. This translates complex digital health data into a dense physical printout. This visual shows the specific formatting of the printout. It is a highly structured, machine-readable document optimized for computers, not human legibility. A legacy clinic ingests this document utilizing standard 2D optical character recognition, or OCR, scanners already present at the front desk. The scanning layer perfectly translates the physical JSON document into structured digital HL7 FHIR data blocks. HL7 FHIR is the global standard protocol for exchanging healthcare information electronically. This offline bridge allows pure legacy systems to ingest modern ambulatory telemetry without any software updates. True system resilience requires a physical failsafe, ensuring clinical data fluidity is never halted by a specific institution's lack of digital infrastructure. This zero-knowledge architecture carries a direct macroeconomic impact on daily clinical operations. This diagram compares the immediate clinical return on investment. Completely eradicating the clipboard reclaims up to 14 minutes per patient encounter, visibly accelerating queue throughput. This creates a powerful downstream clinical impact. It transforms the historically disconnected ambulatory patient into a continuous, structured data endpoint. Ingesting this continuous telemetry allows partnered clinics to legally unlock remote patient monitoring, or RPM, Medicare billing codes, which reimburse providers for collecting and analyzing patient data generated outside the hospital. The system flips patient oversight from a massive administrative cost center into a recurring, structured revenue stream. Maintaining this continuous stream of structured data guards hospitals against severe financial penalties associated with 30-day patient readmissions under value-based care models. Value-based care is a Medicare payment framework that penalizes hospitals for poor recovery outcomes instead of paying strictly for services rendered. Patients are highly incentivized to maintain this data logging loop precisely because the system operates strictly on their behalf as a zero-trust fault. This sovereign edge model stands in direct contrast to legacy monopolies that attempt to trap data within centralized institutional silos. The Human Operating System framework proves that institutional efficiency and absolute patient autonomy are not mutually exclusive goals. Aura hOS does not aim to replace the hospital database. Instead, it establishes the universal standard for decentralized, zero-trust data interoperability, exactly where it belongs, at the biological edge.